Hello, and welcome to the webinar presented in collaboration with the Connecticut, Delaware, New York, Pennsylvania, and Virginia MGMAs. We would like to thank today's webinar sponsor, MagMutual. My name is Erin, and I will be your host. Before we begin, I would like to review a few housekeeping items and let you know how to participate. The viewer window is on the right and allows you to see everything the presenter shares on their screen. The control panel is on the left. That is how you can participate in the webinar. The audio panel provides audio information. By default, you have joined the webinar using microphone and speakers. If you prefer, you can join the audio using your telephone by selecting Use Telephone under the audio drop-down box. The dial-in information will be displayed, including the audio pin. During the presentation, you can send questions through the chat box found on the left side of your screen. Simply type in your question and click Send. Throughout the presentation, our speaker will take questions, and at the end, if there are any left, we will have a brief moment to respond to them. As a reminder, we are recording today's webinar. You can view the recording on participating MGMA websites. Today's presentation is led by Jaci Kipreos. Jaci has been working in medical coding and auditing for 31 years and has been a certified professional coder since 1994. She earned her COC for facility-based coding in 2005. She's also a certified professional medical auditor in the specialty of evaluation and management coding. She's worked in a variety of practice settings and has particular experience in coding for family practice, urgent care, OBGYN, general surgery, and Medicare's teaching physician guidelines. Jaci has been with Practice Integrity since 2003, where she leads a group of AAPC certified instructors in teaching the professional medical coding curriculum. Jaci received her BS in Finance from Virginia Tech and has been an instructor for various AAPC workshops for the past 6 years and has served as a local chapter president and as the president for the AAPC National Advisory Board. Please welcome Jaci Kipreos.
Thank you, Erin. I appreciate that. Welcome, everyone, today. I'm just so thrilled that so many states are participating. That's very exciting. So just want to say in advance, there are no unique guidelines that I'm going to address today that are unique to any one particular state. Everything is more on a very national level. Those are the type of situations that I'll be discussing. Our topic today is maximizing revenue through correct diagnosis coding. I had the pleasure of presenting this topic for the MGMA at their financial conference back in March, I think it was back in March. I'm losing track of time already. And it was an interesting topic for me to be able to present really just based on diagnosis coding. So before I begin, I just want to say, kind of just sit back and relax and kind of let it roll through you. I want you to kind of think out of the box, kind of think about how diagnosis coding is going to affect your claims processing now and what the future kind of looks like. Certainly put in your questions. I will be eyeing that area and we'll be answering them throughout our presentation. If it looks like we're going to run out of time, please feel free to email me. My email is on the first slide. It'll be on the last slide as well. Please feel free to email me, and I'll be glad to respond and answer any questions that you have. If you have questions that come up later, as you look back on the slide information and you're like, I'm not quite sure what she was saying, just email me, and I'll be glad to provide any information that I can to help clarify anything. There's the bio again, and whenever that, thank you again for that introduction. And I do always have to put out there a disclaimer, in particular because we will be talking about some coding guidelines. We know that has changed. We had some changes to evaluation and management guidelines at the beginning of this year. We know some are coming at the beginning of next year. How it'll exactly look, we're not quite sure. But as of today, at this moment in time, everything that's on the slides is correct based on Medicare policy and guidelines. So this is what I'd like to present today. I really want to talk about medical decision-making and diagnosis code, as well as medical complexity. I really want to look at the coding rules for professional fee coding versus facility versus risk adjustment. That's going to be a high level, kind of broad stroke, depending on where you are and what's your venue, how that is going to affect you. I am famous for repeating myself, but some things are very important and need to be repeated. No matter where you are, if you're in a clinic, if you're in an office, and everything you do is pro fee, it's still your provider's documentation that's going to lead to the payment in all these areas. So it's important to understand how their documentation of medical complexity and diagnosis coding is going to affect these other areas, and that's why we're going to talk about it. We're going to talk about how the guidelines for use of ICD-10 codes play such an important role in assuring that we have accuracy in our documentation and coding, and we're going to talk about why that is so important. This is not a coding presentation in the sense that you're going to learn to code. That's just not why you're here. That's not your career choice, most likely. But I think it's important to know where you can find guidelines and understand why maybe individuals in your office or within your hospital are often asking questions of providers and requesting additional information. I want you to know where the information is coming from and how easy it is to find it and how important it's going to be in the future. We're talking today primarily, specifically about diagnostic codes. I think diagnosis coding has been the forgotten piece of auditing and compliance and claims payment for a very long time because we get very wrapped up in our RVUs. However, it's that diagnosis code that's always going to support medical necessity, medical severity, medical complexity. Thinking about what that diagnostic statement is trying to convey on a claim and trying to convey to the payer or the carrier about what was going on that day. I am sure many of you are seeing now more denials than ever based on diagnosis codes. Sometimes it's because unspecified codes are being used. When ICD-10 came out, we had that grace period of 1 year. Payers are getting a lot more specific in their review of your claims, and they're wanting specificity in their ICD-10 codes. Sometimes the denial is not a fair one, but they still need to be reviewed, and when possible, that documentation should be able to support with clarity and specificity the exact nature of problems and conditions and injuries during that encounter. So what is it? In its most simplistic form, what is diagnosis coding? If you were to open any ICD-10 big, huge, heavy book, you would see these codes are 3 to 7 characters. And in the United States, we have ICD-10 CM, with the CM being clinical modifications. As you know, ICD-10 is a global, world way of describing diagnostic statements, but here in the United States, we have the clinical modifications, which makes it very unique to us. But what does that diagnosis code provide? What is it able to do? So many things beyond just considering what that CPT code does. A diagnosis code will track the health history of a patient. You can look over time and see the beginning of symptoms to a diagnosis to what may become a history of, so that patient's progression through conditions. It describes medical necessity, complexity, and risk. And we're going to talk today about risk. We're going to look at medical necessity, and we're going to look at what those words really mean and how we need to approach that in your documentation and how that affects payment. The data elements for population health. This is huge right now when a practice is determining what their patient population looks like, both when it comes to disease process as well as immunization status. Anything that affects the health of that patient, you can pull that data through diagnosis codes if the codes are being applied to each encounter correctly and specifically during each encounter. It's so easy to pull that data. Data is such a big word now. and we are all using data in different ways. And we need to remember that your diagnostic statement and diagnosis codes are a huge piece of data. There's a CDI link. So CDI refers to your documentation. So it's your compliant documentation, your correct documentation. It is now looking at documentation in a whole different format and looking at, was there a piece missing? Did the provider actually account for all the information that was provided, either through x-rays, through lab results? Did they convey it in their final assessment? So we're looking at those diagnostic statements in a much different way now, because we're moving now to something that's more quality-based, looking at how a patient moves through that practice with that provider and how is their diagnosis evolving. Are they improving? Are they getting worse? Do we have diagnostic statements that reflect quality of care? And then that bottom bullet, the HCC and the risk adjustment. Not everyone participates with that. I would think many people are very aware of what it means. We are going to talk some today about risk assessment and how proper diagnosis coding can reflect in your reimbursement on that field as well. So that diagnostic statement and diagnosis coding in today's world, this immediate today's world, when we think about pro-fee, we're still very caught up in our RVU, but if we don't start looking forward now and addressing how things are going to change, we're going to be left behind, and the payment will not reflect appropriately how hard the provider is actually working. On that claim form, that diagnosis code is going to finish the story for you. CPT codes, RVUs, CPT will always tell what was done. That's the whole point of an AMA CPT code. That's the only reason AMA created CPT, was to make it easy to convey to a payer what did the provider do that day. It's 5-character, this is what was done. Why was it done? What was the importance? What was the medical necessity? Why was this performed? That's your ICD-10 code. That gives you all the rationale behind whatever service was delivered. It's a good match, and it should match, and we need to take it very seriously. So how is this going to work with your payments? And again, I know you're thinking RVUs, but think about those denials due to medical necessity, a mismatch of a diagnosis code and a CPT code, or a diagnosis code that now has an unspecified code. Thinking about audits for particular specialties that use unspecified codes to represent a diagnosis that is their specialty. Oncology using unspecified codes when you know they have the exact information of the location of the malignancy. Same with, you could use that with any specialty, neurology, urology, when that specific information is known, it's been documented or has been documented in a prior note and is not reflected on the claim, no one's doing themselves any favors. Those diagnostic statements can defend or support a high-level E&M code. Yes, our E&M codes are going to change as far as the rulings. We feel very confident that 2020 there'll be some changes. But if you've done any reading on what the change will be, the change is going to be that everything will be dependent upon medical decision-making. And we'll defend that with diagnostic statements. That's how you're going to reflect why you have a certain level of service. That's what's going to reflect how hard that provider worked that. My opinion has always been a level of service selected by a provider will always convey how hard that provider thought they worked that day. But their diagnosis codes will always tell how hard they worked that day. So when they code properly and convey all the codes they should to truly reflect the patient's experience and their status during that encounter, it will show how hard they worked. Inpatient DRGs, you do not have to be working in a facility and billing facility to know that that DRG payment is based upon your provider's documentation. And that total payment scheme is truly built around diagnostic statements. And then, of course, risk adjustment in those payments as well. So we're going to touch on each of these a little bit and talk about how that affects the payment and where the information is coming from. And again, that diagnostic statement and how it becomes more and more important all the time. I did go to some individuals in the field. You may recognize some of the names. If the print's too small, I have spoken with a CFO, a CEO, and then someone who is on the payer side to get their thoughts on diagnosis coding over the past 3 years and the biggest changes. And each of them, because of their perspective and their particular jobs, have really accounted for the things that I see most as well, and you may share their thoughts. From our CFO, the problem with a lot of providers right now is accommodating this change in the need to truly reflect the patient at the time of that encounter and accounting for all the conditions that were present that affected some sort of treatment. And we'll look at that guideline from ICD-10. And from the payer world, they're looking at the shift to value-based reimbursement, and that is the shift we're moving to, and that value-based is going to be reflective in that ICD-10 statement. And from our CEO, I think what's really key here is the data analytics. I had a hard time with that one. When I was at the financial conference, MGMA financial conference in Vegas, and I was speaking on this topic, I was fortunate enough to attend a couple of the sessions, and each of them was dealing with data. And in each of the sessions, they came back to diagnosis coding and how important it was to gather that data to have some sort of information to work with when you're talking with your payers or looking at your patient population. It was amazing. They were helping me get to my presentation. I mean, we were all working together with the same thought, but I thought it was amazing just walking into these presentations and listening to some topics that I had not heard before. They were playing right into what I feel strongly about. But the data is so important, and if you're not tracking your diagnosis codes, now is the time to start doing that. Data is so important. But I thought it was interesting to get perspectives of different people in different areas, and they all are seeing this change, this incredible change towards a more value-based, risk-based, and diagnostic-based payment future. So let's get in. Let's talk about how it all works together. Let's start by making some distinguishing differences between medical decision-making and medical necessity. These terms are sometimes used interchangeably, but they're actually quite different. Medical decision-making is exactly how it sounds. It's a thought process. A provider sees a patient and listens to a history, performs an exam, has some other information available, and based on findings, comes up with a decision. Either we have symptoms, we have a clear diagnosis, this is a patient with chronic conditions, and then they are able to determine diagnosis and treatment. That's decision making. As we know, that's one of the key elements in determining the level of an evaluation and management service, and that will be the key level, and CMS and AMA will finally state that, we believe, in 2020. But we're going to look at where in the past they've made it clear but haven't been as loud saying it. Medical necessity supports the need to provide any service. It's not unique to evaluation and management. It's the necessity to provide that service. It's a way to say, this is what we performed, whether it's a lab, x-ray, procedure, E&M service, major surgery, whatever it is, here's the need. This is the diagnosis. This is the reason to do this. And this is where sometimes in the past, and especially now, we're seeing denials because of that, not having a good match with these. So going way back, 1991. So the winter of 1991, this is when the CPT Assistant newsletter used to come out quarterly. And this was the last quarterly newsletter before the E&M section was formed in the CPT book. So we'll take a little history lesson. But I find it interesting that this statement, so important, was noted in the CPT Assistant, but this statement really was never made clear in the CPT book. And this is where the AMA first started telling us, look at your medical decision-making first. It is the most important thing to do, keeping in mind that medical decision-making goes directly to a diagnosis code. They tell you, determine the complexity of decision-making. You must determine complexity separately and distinctly before factoring this into the code selection. Start with decision-making, then relate it back to history and exam. Get the complexity first. Think about how hard you're working. If you're the provider, think about how hard you're working. How many things did you have to think about? How many conditions does this patient have? Whether you're treating all of them or not, how many do you have to consider? That's where they wanted you to start. They don't make it really clear, but they are telling you from back in 91, this is where we want you to begin. Medical necessity from a reimbursement level. So that was medical decision-making, medical necessity. The AMA has always said, healthcare services are products that a prudent physician would provide to a patient for the purpose of preventing, diagnosing, or treating an illness, injury, disease in accordance with generally accepted standards. So this is medical necessity. How important was it to perform this service? Where in this diagnostic statement can we make it clear that there was a reason, a medical reason and necessity to provide the service? This rule has been around forever and it's not going anywhere. It's just becoming stronger. And that diagnostic statement and those diagnosis codes are going to make it clear how important it was to perform a service for this patient. CMS has always made a statement about medical necessity as well. Very clear on payment. They're not going to make a payment unless the service was reasonable and necessary for the diagnosis or treatment. They're going to look at a diagnosis and determine if it was necessary to perform this service. And that can be any type of service. Medical necessity, CMS continues with making a statement as far as a reimbursement issue. In their internet-only manual, the claims processing manual, I love that they make the statement about the amount of documentation. The amount of documentation should not be the primary influence upon which a specific level of service is billed. Documentation should support the level of service reported. And, of course, they always make the statement that someone should document soon after seeing the patient. But medical, they start off by telling us medical necessity of a service is the overarching criterion for payment. Medical necessity. And that comes through a diagnosis code. And, again, this will reach a very important, crucial part of the payment process as we head into 2020. We're beginning to see it now more so than before, but we're going to see it more in the future as payment methodology evolves into this. Medical decision-making, medical necessity. You have a 1500 form, and your ICD-10 code will convey this information from that perspective. So I have to pause now and be honest about what I'm saying, because I do live in the real world. And since ICD-10 has hit the ground, and since we've been using it, the one thing I have noticed, and I'm sure you have seen it and felt it and heard it as well, most of our software systems, most of our practice management systems, our electronic medical records, were not geared to make diagnostic coding easy. Our EMRs for clinic visits, office visits, and hospital visits were geared towards making evaluation and management coding easy. Templates, having it very easy to put together a note. But it was never made easy, and I've yet to see it made easy to change a diagnosis or find a diagnosis. So before I go any further, let me say I understand and I appreciate, and I wish I had a magic answer for the fact that when you embrace the need for better diagnostic statements and better, clearer diagnosis coding, it's not going to be easy. And it will be time consuming, and the providers will have difficulty with many of, and I'm not saying all, but with many of the electronic health records and medical record systems where you have to create that assessment. And when you go to create that, it's sometimes very easy to use an unlisted code. It becomes very easy to use what you've used in the past, but stopping and making something better and making it correct and pulling in new diagnosis is time consuming and difficult at best. So I just want you to know I know that. So that's why if we can start thinking about it now and working with maybe some of your vendors to find a better way. I just don't want you to think that I'm just saying all this and thinking it's easy and, oh, everything will be delightful and you'll make changes immediately. I understand that this is different, and we have worked very hard on making our CPT world work very easily in a world that now is going to kind of move towards diagnosis coding. So the question on the board is, we are limited to 12 diagnoses per claim. How can providers work around that restriction? So the one thing I often say, because when I look at a CMS 1500, some people limit themselves to 4, some use 12. My take on it, most payers are looking at your top 1. They will take everything you give, but they're looking at your top 1, maybe your top 3. I think what's most important is that you were very clear to start off with a really good first 2 or 3, especially a first diagnosis. And we're going to look at some examples of that towards the end of the presentation. The most important thing is that everything was clearly documented and the assessment can be supported in the documentation, so that whatever assessment's on there and whatever diagnosis codes you're popping on a claim, if someone requests a record, it's all in there. I'm always going to rely on the note. The note will have everything I need in it. I want those diagnosis codes, and if you're going to use 12, make them the best 12 you've got. If there were more and you couldn't put them on the claim, have them documented. That way, if someone ever questions something, it's in your documentation. And some people do limit themselves to less, but the documentation is in there, and that's why it's so important to prioritize and reflect properly, and we will look at some examples of that. So I'm going to go back to some things we've seen before, but I want to look at it in a different perspective. There are guidelines that have been around for a long time, a very long time. But we need to look at these. I'm going to look at the Medicare documentation guidelines for evaluation and management. Been around since 95 and 97. But I want to look at them from a different perspective. I want you to think about what they've been telling us for all these years that maybe we ignored a little bit. But since the beginning, they've been pushing diagnosis coding, and we've been pushing CPT coding because that's what we thought they were talking about. So I'm going to go back through these guidelines briefly, but I'm not talking about bean counting, how many pieces of history, how many pieces of, no, I'm not talking about that. I want to talk about the beginning of the guidelines when they tell us what's a complete piece of documentation. What makes it complete? And let's look at it from the perspective of diagnosis coding. They were telling us a lot. So back to the guidelines. This is straight from the 95 and 97. The medical record should be complete and legible. That's fine. Going through what makes it complete. Reason for the encounter. Well, that's a diagnosis code. Findings and prior diagnostic test results. Those are diagnosis codes. Assessment. diagnosis codes. So the things that have to be documented that make it complete are diagnosis codes that we should be reflecting on that claim form. They go on to say, if it's not documented, rationale for ordering diagnostic and other ancillary services should be easily inferred. Well, if I can infer it, there's a diagnostic statement in there somewhere. Past and present diagnosis should be available, diagnosis codes. Appropriate health risk factors. This one is so important to me, and we're going to talk about health risk factors towards the end of the presentation. But I want you to remember they said it. Now, I'm going to take some liberty in the interpretation here because I think it's very important. When these guidelines originally came out in '95, health risk factors were referring primarily to risk to a patient following perhaps a surgery, the days following a surgery. But they also meant risk factors to the patient themselves. What about their health scenario is causing risk to them? And that's what we're going to talk about later on. And having your provider make sure they document that risk and code for that risk, because it's very important to do so, because that's medical complexity. Patient's progress, response, and changes in treatment. Progress and response, that's diagnosis coding, because that diagnostic statement can change from visit to visit. If it's hospital visits, it can change from visit to visit if they are improving, if something no longer exists, if now you have lab results and you can get specific as to the particular type of infection. So if it's on a claim form, I get to audit it. So everything that's on that claim is open to audit, should be documented somewhere, and should be supported in that documentation. Looking in your CPT book, subsequent hospital visits. We may think they're talking about the work that was done, but really, if you think about it, they're talking about the status of the patient, which is a diagnosis code. 99231, stable, recovering, improving. That should be in my diagnostic statement. So I should have codes that reflect that that patient has improved from the time that they were admitted. 3.2, responding inadequately to therapy, minor complication. So now I'm perhaps seeing a diagnosis that I didn't see before. Maybe we've added specificity to show that that patient now is not doing as anticipating. And 99233, unstable, significant complication, significant new problem. I want to see a different diagnosis than the day before. If the day before it was a 3.2, I want to know through that diagnostic statement why these codes were selected, not just on the amount of history and exam. I want to know, based on the complexity of that patient and the status of that patient, why these codes were selected. And that's what they are truly talking about in these code selections. They've been telling us this for a long time. We've just been hanging in on RVUs and payment of that type. And we need to reflect now on the status of the patient, the complexity of the patient, and how hard is the provider thinking on this day. So for facility payments, we know it's based on a DRG. And again, even if your job is not in the facility figuring out the DRG, the individuals in the hospital, in the HIMSS department, who are extrapolating information out of a medical record to formulate a DRG are relying on your providers and their documentation to get that DRG. So those are the individuals that often go back to the provider and query their notes, ask for clear specificity, inquire about certain conditions that perhaps were not a part of the assessment, that perhaps were noted somewhere else in the note, and they query the provider as to the existence of these conditions. A DRG is put together based on a payment scheme that looks at a patient population and diagnostic conditions and the potential for how long that patient may stay in the hospital and how many healthcare dollars they may consume during that stay. But the things that go into a DRG and what someone is considering are all built around the diagnostic statement outside of any primary procedures that may be performed. The idea of this case mix, all built around that patient status and severity. As you can see, the severity of illness, prognosis. I just want you to have that information so that if you ever hear back from your providers that maybe they get a lot of queries or maybe someone is questioning their documentation, this is what the people on the inpatient side, the facility side, have to consider when they're thinking about how that DRG is going to be built and how it's going to affect the payment to the hospital. And again, this is just a continuation of what goes into the formula for a case mix for the facility side. And just a reminder again, it's the provider's documentation that's going to lead us there. So that's why we stress the importance to our providers that no matter where they are, it's still their documentation that's going to push and move these things. For risk adjustment, again, this is not a lesson on how to code or extrapolate for risk adjustment, but the concept is the payment that comes from risk adjustment is based on the fact that patients with a more complex diagnosis require more health care dollars, more health care time with a provider, so therefore the payment is a little bit more. Now, where we start to get confusion and it becomes difficult sometimes is the rules for risk adjustment coding and extrapolation are different than the world for pro fee. So I will often see providers documenting to satisfy risk adjustment standards, but they do not satisfy coding standards on a Part B claim form. We are in two different worlds, but the worlds will be merging, I believe, in the future. But for now, the rules of extrapolation for risk adjustment, what codes they can use, and how they read a record to extrapolate a code or a diagnostic statement are different than if I were doing an audit based on a Part B claim form. I have to use the rules from ICD-10, not risk adjustment. But at the end of the day, what we all want is the provider to document how hard they were working that day by clearly identifying all the conditions that were addressed and all the conditions that they had to consider, and make sure they document to all the specificity that was available at that encounter. So for risk adjustment, they have a whole different payment scheme, so to speak, where they categorize diseases into groups based on their clinical nature. Those that are very similar are based together, and then the payment is based on if you fall into one of those hierarchy or groups, if that diagnostic statement or code falls into one of those. Risk adjustment methodology, mentality is starting to come into many facets now, not just that Part C with Medicare, but Medicaid is using this. Commercial payers are beginning to use it. You're starting to hear this language spoken more often, and it's becoming a more primary focus for providers as well. A lot of providers have a very good understanding of risk adjustment and the importance of documenting properly to make sure that their payments for that are proper and are beneficial as well. So we lean on our guidelines. So now we've talked about different ways that correct diagnosis coding can affect payment in different types of scenarios. Right now, when we talk about these guidelines, I'm really going to lean back on the Part B side of things and look at guidelines, how they are important for day-to-day environment, not necessarily just risk or DRG, but your Part B claims and not even for your commercial payers, but on the pro fee side. So when we go to the official guidelines for diagnosis coding, I'm not assigning that for homework to anyone, but it's good to know that they're there. And we do have rules to follow. Just like in your CPT book, there are rules we have to follow for diagnosis coding. And good diagnosis coding and review of those diagnosis codes should be a part of any audit that you're performing in your office, because there are rules that have to be followed a certain way, and not following the rules can result in claims denials. So the guidelines are found in your ICD-10 book. However, most years, I never say always, but most years when the new books come out in October, the guidelines that are in there don't reflect the new ones, because the new ones came into effect too late to be a part of the print of the book. So if you were to look in your 2019 ICD-10 book, you would see guidelines for 2018. But you can download the official guidelines. I've got a website link, or you can just Google them, and that works really well. And it's just a PDF form, and I always just download those separate and keep those for reference for the current year. And there's not always huge changes, but if there are any changes, you want to be aware of what they are. I'm not going to go through all the guidelines. I know everyone is sad that I'm not going to go through each and every one of these guidelines, but there are some that are very important, and you may have heard of them before, but I think that it's important for you to know what they are, whether you're coding or not. And I doubt a lot of folks participating in this webinar are actually doing the coding, but I know you are responsible and need to be aware of what's going on. So I want you to have a good feel and understanding of why sometimes questions come through or why denials come through. So from the guidelines, we're just going to look at the ones that are most important. There are many of them, and it's really not a bad read. We have a section called just General Guidelines for use for the entire book. It tells you how to use the book. The ICD-10 book has a very unique structure to it. It explains how to read it, how to use the format structure. It provides meanings to all the symbols that you find in the book. And as you read through the tabular portion, or what we call the code sets in the ICD-10 book, there are instructions along the way, and the general guidelines tell you how to get through the section guidelines, or the guidelines and instructional notes within the codes themselves. And those are real important to read as you go. And you learn how to use the index. So these are just your general guidelines, and helps you just kind of get through the book. There is a definition for principal diagnosis. This is often used more within the hospital inpatient side, but we can apply it to the outpatient or Part B side as well. It's the circumstance of why the patient had an encounter. That's your principal and should be always your first listed diagnosis. So it's always concerning to me when I'm performing an audit and I see a chief complaint and the patient maybe has a pain in their arm, and then they have some other conditions, and maybe they're come to their primary care doctor, and I get to the assessment and the first listed diagnosis is depression. And I'm like, where did that happen? Or the first listed diagnosis is hypertension. Where did that come from? Because the patient presented with the chief complaint of new pain in their arm, and that got a workup, and there's a diagnosis, and there's some treatment, but we're going to use something else because that's what we've been using for the past 3 visits, and it's too difficult to change things around. That first diagnosis needs to indicate why the patient was seen on that day. If there are 3 important reasons that patient was seen that day and no one took priority, then it's at the provider's discretion. However, if one truly took priority, that should be that leading diagnosis. That's the reason the patient presented. That's the reason for the encounter. This is the one that's really hard. This is the one that's causing the most problems right now with providers, and I'm pushing it hard for their benefit. Providers should document and code for, document conditions that coexist at the time of the encounter and require or affect patient care, treatment, or management. If it affects patient care, so I'll just use my prior example. Maybe the patient does have limb pain, arm pain, but they are depressed and they are on antidepressants, and maybe that medication is not going to set well with the first thought the provider had for pain medication. Then they had to consider depression. Should that be my first listed? No, but you get to list it. If the orthopod is thinking about providing a joint injection, but the patient is a diabetic and they're concerned about having the steroid with the patient that's a diabetic, they're not treating the diabetes, but they had to think about it. They should list it. This is complexity. They had to think harder than the patient who was seen before who wasn't a diabetic who got the joint injection. If it affects treatment, the documentation needs to indicate in the assessment those other conditions that they had to consider, and they can make a statement that diabetes patient being treated or being seen by their endocrinologist. A simple statement of their concern, why this is important, not a dissertation, but it needs to be brought in together. Don't code conditions, though, that don't exist and have no bearing on that visit. But history of codes are great if they have bearing on that encounter. History of conditions, family history of conditions that have an effect or bearing on that encounter should be noted. This is hard for providers to get used to. It's difficult to add these codes, but it is so important to provide that complexity. This is how providers are going to tell how hard they've been working. This is how it's going to happen, and this is what we need to move towards. It's a guideline. This is not something I'm making up, just saying, oh, this would be a great idea. We've been told to do this, and it should be done. Some guidelines speak to specific diagnosis codes. And again, this is not a coding lesson. This is just a reminder. Hypertension is one of those conditions that gives us multiple codes to choose from, and we have combination codes. So if in the documentation I see in the assessment the patient has hypertension and chronic kidney disease or heart failure, I'm going to use a combination code, one code that's to describe 2 or 3 things that's going to pack a lot into that one code and show a lot of complexity instead of 3 separate codes. All the provider has to document is if there is no direct correlation between the hypertension and chronic kidney disease or hypertension and the heart failure. But we have ways to combine these into one diagnostic statement. So this is straight from the guidelines. So we have a code. Hypertension is I-10. Hypertension with heart failure is I-11. Hypertension with chronic kidney disease, we have 2 codes to choose from. So we're combining things. And I-13 is a patient with hypertension, heart failure, and chronic kidney disease. One code sending out a big message of 3 things that provider had to think about. Diabetes the same way. We have to consider the status of the patient. Use as many diabetes codes as necessary to describe the status of the patient on the date of that encounter if the provider is having to consider all these different complications due to diabetes. Don't limit yourself to the one diabetes code that said no complications when the documentation clearly reflects there's some things going on with the patient. Use as many codes as possible. State the type of diabetes. We cannot infer just because the patient is on insulin that they're type 1 or anything else. If the type is not documented, my rules tell me I have to default it to type 2 or unspecified. They're the same. The I-11 is type 2 unspecified. That's what we have to do. So we want to document the type. And remember to add the additional code if it's documented that the patient is on insulin and they're not type 1. That's complexity, and it's a way to convey it. And I see a question. What about when patient presents for their annual ACA routine visit? During the conversation, they bring up past history of hypertension. The patient presented for routine visit, and once they're free, no copay visit. That's a difficult situation. One from the coding of the CPT part of it, and one to the provider. The provider has to make choices there, and I don't know if you have a policy within your office that you're only going to do one thing, not two things, and it makes it very, very difficult. As far as the diagnostic statement, if the provider has provided any treatment plan or talked about any other conditions during that routine visit, then definitely it can be a diagnosis on the claim. It wouldn't be my first listed one because you're going to bill that CPT code for that routine, more preventive visit. It becomes a difficult situation. In fact, if you would email me that question, we can talk about it in more detail, and I'd like to ask some more follow-up questions from you from that as well, because that's a hard one to do, but I get that question a lot. So my email will be on the last slide, and it was on that first one, but please email me that, and let's continue that a little bit more. It is a problem both on the CPT side. Definitely want to get that diagnosis out there, but you may not, it's not going to provide a whole lot more, but you still want to show what you're doing. This is the risk factors I was talking about before. These diagnostic statements should never be left out if they've been documented or if they represent the patient. Especially on the inpatient side, some of these conditions can lead to an extended stay for the patient. These are risk factors. This is a concept that I honestly understand from the provider's perspective is difficult to get across, and I appreciate that and I understand it. But at some point, and let's be clear, this is the business of healthcare, at some point the patient needs to be partially responsible for their healthcare as well. If patients are truly not doing as asked or showing improvement because they're not making lifestyle choices to make themselves better, but your provider is working very, very hard to want them to be better, and payers are looking at quality of care based on diagnosis, we have to consider adding these risk factors so that we can reflect an honest picture of the patient. I'm going to use the one for noncompliance because that's the one that providers have a really hard time with. But think about that patient who may be readmitted to the hospital because they were not compliant with their medications. They were not compliant with the rules and instructions. Now you have a patient who's being readmitted. That may not look good on a quality report for your provider, but they've done all they can as far as providing good information to the patient. So we have to have a team effort here with patient and provider working together. When you have a patient who's a smoker and is recovering from surgery, every surgeon knows they're not going to recover the same way. These are risk factors. They need to all be identified. Obesity as well. And this is not making a judgment or statement about any patient, and I'm not inferring that as well. But at the same time, with value-based and looking at quality, this has to go into the picture, and your providers have to find a comfortable place to put this information on that claim form and make sure it's documented. So you have to think about what your first listed diagnosis is saying. If the payer is really going to hang their hat on the first one, what's your first one saying? What does it say about how hard your provider is working? So just some quick examples. Here's a patient with hypertension with chronic kidney disease, stage 5, and a patient who is a smoker. You can do that in 2 diagnosis codes, 1, 2, 3 diagnosis codes versus just hypertension. But that first diagnosis, if you do it right, will involve hypertension and chronic kidney disease. That one code will say that patient has 2 conditions versus just saying hypertension. Diabetes type 2 control with insulin in a patient who is obese and a smoker on antidepressants versus diabetes, just saying diabetes. You can say a lot about a patient in a few diagnosis codes if you document it right and get that clear picture going. And a patient with hypertension who has been non-compliant with medication and now requires hospital admission. Make sure you're telling the true story to get everything across. I'm going to kind of end this up with an example for risk adjustment and then just go back to what some people feel is coming in the future. Again, risk adjustment doesn't may not apply to everyone on this call. However, the concept should. I've highlighted in red. This is a note that a physician used at the financial conference, and I liked it, and he let me use it, and I just changed a few short things on it, but I highlight in red where your eyes should go right away. So I'm just identifying what was good in this documentation about this patient. The provider documented very nicely what was going on with the patient. We have a lot of conditions here. And it can be coded a couple of different ways. You could just say the patient has type 2 diabetes, mention their pulmonary disease, and shortness of breath. And your total HCC score would be 0.402. And you'd have it, you know, there you go. Their peripheral arterial disease, saying it's related to the diabetes. They've got breathing, pulmonary issues, diabetes. All of this is in here. And they chose to go with just diabetes, PAD, and shortness of breath. You could put it all together and code correctly, and this is what it should be like for risk adjustment or not, but your risk adjustment total will increase. So you can make it better by good documentation and coding accurately. So I went back to some people again. I asked them what they thought was going to happen in the future. So again, I've got a CFO, I've got a compliance officer, and someone from the payer side. And everyone feels that diagnosis coding will become equally important to that RVU, wherever that RVU may go. And that we're going to be looking at that patient's clinical condition in a much clearer aspect. And the trending of value-based and trending of quality will start to incorporate itself into the HEDIS measures and Medicare stars as well. It's just going to keep going. And then, of course, just as we start to really grasp this and feel it, we're going to have this. We will have ICD-11 as well, but not to alarm anyone. But yeah, it's going to come to you. But we're going to be so comfortable with our diagnosis coding and feel real good about that. That we'll be comfortable when ICD-11 comes. It will look very much like ICD-10. It will not be the huge change from 9 to 10. It will be a very, very comfortable change. Yes, I believe you'll get a copy of the presentation. Someone here will be able to answer that for you. We've just wrapped up our hour, and I really appreciate your being on the call today. I hope that was informative to you. I hope I've stressed what I believe and others believe as well is the changing environment and the importance of changing with your providers. The documentation for your clinical documentation improvement issues, the risk measures, just the total payment, and the need to show complexity and need to show that true clinical statement through your diagnostic statement and the documentation, as well as specificity and severity and complexity, and the ICD-10 codes on the claim form as well. And I do have my email here again, Jaci, Jaci, @practiceintegrity.com. If I've left you confused, I apologize. If you have questions, please email me. We'd be glad to continue the conversation with you via email. I hope y'all have a great weekend, and hopefully the rain will stay away for a wonderful Mother's Day weekend for everyone as well. Thank you very much for your time today.
Thank you, Jackie. Thank you all for joining today's webinar. The link to the recording and presentation will be distributed by each state affiliate through email. You should receive that email through the state affiliate that you registered through in the next week. Following the webinar, you will be sent 2 brief surveys. One will ask you to rate the webinar using a 5-star scale. Then you'll be sent a separate email and link to our online webinar survey where you can provide us with feedback about today's presentation. Please take a few minutes to complete both surveys. If you're a non-member, please consider becoming a member of your respective state affiliate. This concludes our webinar. Thank you for your participation and have a wonderful afternoon.